I'd like to address the graduating class. It's 1960, I graduated with 52 colleagues. It was a huge day in my life. I know it is in yours. Guests, faculty, it certainly is an honor to be here. I, at the age of 17, contracted rheumatic fever. And this was a polyarthritis. All my joints were swollen. I couldn't eat anything. I had a high temperature. And the medical treatment for that in those days was 3 aspirin every 4 hours around the clock. And after 3 months of being in bed, never touching the floor, I weighed about 100 pounds, and I was not doing well. The MD who visited weekly said to my dad, you know, 42% of kids that get this die, and 85% have serious heart trouble for the rest of their life. And he left. My dad went immediately, got on the phone. In those days, phones were nailed to the wall, but that's aside. Dr. Murphy was up the street, a chiropractor, and my dad explained the situation, and he said, oh, I'll be right down. So he arrived with a portable table. They lifted me out of bed. He laid me face down, palpated along my back, and did a huge adjustment between my upper thoracics. I thought he broke my back. It was unbelievable. However, the next morning I woke up, my dad came into the room, and I said, you know, something's happened to me. I think I'm going to be healed. I think I'm going to get better. I'm going to get out of this bed. And that's what happened. Gradually, the swelling went down. I was able to walk and get a shower, and I got stronger and stronger. I was preparing for chemical engineering, education-wise, and I thought, you know, I really should join chiropractic and help people get well that medicine can't get well. That was my concept. So I entered chiropractic college in 1956, and I graduated in 1960, and I still didn't know exactly how I got over rheumatic fever. There was a lot of concepts thrown at me. There were a lot of things. I was taught how to manipulate, adjust, but it was never really explained what the protocols for getting somebody with an autoimmune disease well. Well, I was very young at the time, and I went north to a small village of 3,000 people where the chiropractor was very busy. The MD in town was a drunk, and nobody would go to him. So we had a very general chiropractic practice, saw all kinds of conditions. And I would go down the hall and say, Dr. Curry, what am I going to do? This baby's got eczema. And he'd say, adjust. And then somebody would come in with something else, and I'd go down the hall and I'd say, Dr. Howe, what am I going to do with Mrs. So-and-so? She's got, and he'd say, adjust. Well, that was great, and I saw all kinds of things respond. But I really didn't know until 1962, when I went over to Europe and attended a seminar or a symposium, the European Chiropractic Union. And Dr. Fred Illy, who was an engineer chiropractor in Switzerland, he had devised how to use X-ray to produce motion X-ray pictures using a fluoroscope and a 16-millimeter camera. You remember the old reels, and they had to click on through, and Well, that's what he presented at this conference, 2.5 hours of what we would call video today, of how the spine moved and how it didn't move when people came to him, and then he would adjust them and he would use apparatus that would be today called rehab. And then he would recheck them with this video and show how the spine had achieved normal motion. These little kinks that didn't move and these little hypermobilities that developed above were gone. They had a nice smooth ability. Their spine, each vertebra floated like it was a swan floating on water. Well, we know the disc is almost all water, and so it should. The spine should function just like swans on water. And it was very interesting because I had a concept at that time that we were changing the alignment and the position of vertebra. And the next day, Henri Gillet presented how in Belgium, where they weren't allowed to take any x-rays, how he was able to figure out how to palpate those motions that Illy had demonstrated on his moving x-rays. And he studied a lot in Switzerland, going over with Fred Illy, how to put this into the hands of a chiropractor, how they could actually achieve the changes that were being shown on that motion, on those motion films. So I went back to England, where I had worked for 6 months in an upper cervical practice, and I saw the results of just adjusting atlas, occiput, atlas, axis, and it was quite incredible, the results that were achieved in this practice. Not quickly, over a long period of time. When I left there, I opened my own practice down in Southampton, and I started to follow what I had been taught in an examination way, what I had learned from a manipulation point of view, what I understood from seeing the dynamic function of these motion X-ray studies. And it was incredibly interesting that I became predictive as to what was going to happen when I achieved the normal mobility of their spine. And then 37 of us in England decided we would get a chiropractic college going. And because I was 30 miles away from the city it was going to be in, I was appointed to the committee that was to put together the clinical chiropractic program. So I realized I didn't know anything about that, and I decided to go and get a whole lot of books. I had 2.5 years to get prepared, and lo and behold, I found out there was a lot of literature about what we did. And there was a lot of literature about how you learn a psychomotor skill, a lot of literature about how to teach a psychomotor skill. And I thought, wow, we got to put this together and create a curriculum where the students will develop the skills and an attitude that these skills take a long time to become consciously competent. There's levels of learning a skill. There's unconscious competency. That's the pro. But to start out with, there's conscious incompetency, and that's where quitters quit. If you didn't become a pianist or a tennis player or some skilled thing, and you maybe tried, you didn't like the feeling of being consciously incompetent. But if you practice, and if you make a habit of learning that skill, before you know it, you're consciously competent. Now, in my opinion, you can apply that to a patient. And if you do that often enough, you eventually become unconsciously competent. You can be looking out the window and adjusting somebody's cervical spine. Right? It can become a habit. But nobody wants to go to a doctor who's just applying a habit. You have to apply your diagnostic and examination facilities. So what's happened to chiropractic, and I've lived through it, is that we're into a huge paradigm shift. There was a time when we graduated as real expert at manipulation, and our diagnosis was subluxation, which interfered with nerve interference that caused bodies to be sick, right? But I learned that chiropractic was a science, art, and philosophy. And I kept thinking to myself, where's the science, right? If we are a science, art, and philosophy, surely we should be addressing the science and not just going with something that somebody said in 1895 or 1930. Did anybody come here on a horse? No. Did you come in a Model T Ford? No. Right? Every science progresses. Science creates experiments, and you make conclusions from what you've experimented with. And those conclusions change as more and more evidence comes along. So science is ever changing. And luckily, in 1963, when I was asked to form a program for AECC, I realized that I hadn't really done a lot of studying of science since I graduated. And I decided, you know, I think I should start putting an hour a day aside. And I'll study things that I like, right? Not that I have to pass an exam. And inflammation was really expanding. The science of inflammation was changing so fast in those days. So I decided, well, I'll study inflammation. And biomechanics, there were no biomechanics books when I graduated. And biomechanics has become now, you can get a PhD in biomechanics. There's so much known about it. And you can study that if that interests you, because it directly is affected by our adjustments. The soft tissue issues. We were told that you just hire a massage therapist and that'll handle that. Well, science has come along and there's now trigger points, and they cause symptoms just like nerve interference does. There's fascia. When I took anatomy with the cadaver, we cut off all the fascia and threw it in the garbage, in the bin to be buried. We didn't even look at it. Right? And today now we're finding out it has a lot to do with how the body is controlled. There's mechanoreceptors, nociceptors. There's all kinds of information going back to the brain from the fascia. And the fascia can hook up and not be sliding like it should, and it'll produce pain patterns that are just like pains that come from what we deal with. Dr. Warren Hammer heard me speak many years ago. And he came up and he said to me, you know, you've touched on soft tissues And I heard you speak once before, and I couldn't find very much about soft tissue. So who wrote a book on soft tissue a few years ago? Dr. Warren Hammer, right? He took it on himself to delve into all the literature and find out what is it that's in the soft tissue field that you as a practitioner can do. Not massage. Right? The paradigm has shifted. It's shifting. You have the decision. Will you be part of the shift and keep studying now that you've graduated? You have all the tools to use. You've been prepared to become a professional. You've been prepared to develop. What if you were graduated as an aeronautical engineer when the Wright brothers flew? And you decided that you were just going to design biplanes with a single propeller at the front. You wouldn't have lasted. Society doesn't accept. You have to move with the science. That doesn't mean that our manipulations of the past aren't any good. It just means that we have to know when, where, why, how, and how often to apply those manipulations, and along with what. RCTs have been trying to figure out what manipulation can do. And you do a cervical manipulation 2 times or 3 times, and people with migraines don't get better. Well, who does that? I treat migraine patients for months, and I see them gradually get less severe and less often, and gradually, and 6 or 8 months later, they come in and say, you know, I haven't had a migraine for a month. Good. I'll see you every month, and we'll keep you that way. Now we know why. With neuroplasticity coming along, there's the science of how the brain can change itself dynamically to a chronic pain. And you have to keep a patient well for 6 or 8 months to reverse that change in the brain. It's relieved me tremendously. I've always treated patients for a long time, over a series, gradually working down. And I often thought, well, I know from experience this is what I have to do. But now we're beginning, science is catching up with us, and we're beginning to realize that we're influencing the brain tissue. We're down-regulating pain from the brain. It's incredible what's going on. And you're sitting there, and you're going to enter into this world, and you have to, in my opinion, make the decision, are you going to take the basis for what you're doing and then start even developing it more? I hope you do. There's an old saying in my family, admire the man that seeks the truth. Beware of the man that's found it. The dean of a very big university in the US here, or the originator of the university, he said, if you don't stand for something, you'll fall for anything. Right? And that's where we were in the 30s and 40s. And now it's so much more sophisticated. It's so much more complicated. However, it's the same situation. You have to be a healer. You can't dispense chiropractic like a prescription. It's an encounter the patient has with you. You have to make it an encounter. Just remember, your physical examination, your workup, will determine how you practice. If what you take are some upper cervical films and you get a listing for the atlas occiput, atlas axis, that's what you'll do. I was in that kind of a practice for 6 months. I didn't know at the time, but when I went into practice on my own, I realized, I'm not using what I was taught to do. Pardon me. I was taught to examine a patient. I was taught to know whether they had slightly high blood pressure or very high blood pressure, were their ankles swelling a little bit, were they overweight, were they deconditioned, how are they going to respond to what I want to do? What you're going to be doing is patient-oriented practice. You can't have a formula that fits everyone. You have to decide what that patient is. I saw a marvelous little YouTube film, and a very famous chef who wrote recipe books said there's no such thing as a good recipe. And he explained how he devised this recipe where he fried fresh pears, added syrup and caramelized and cream, and he got a fantastic, and he wrote in his recipe book, it takes 30 minutes. The next time he did it, in 10 minutes, the pears were ready because they were much riper pears. So he had to change, and he had to adapt his recipe, and 15 minutes later, it was all ready. And then the next time he did it, the pears weren't really ripe at all. And it took 45 minutes to get caramelization, and he had to add water because there wasn't enough juice. In this, the patient is the pear. Your patients are individually different. They have stress factors that will delay their healing process. Or maybe they have very little and a couple of visits and they're better. Or they may be like a patient of mine. He came to me at 84 and he said, I've just been to an orthopedic who told me I was 84. He said, I already knew that before I went there. And he said, I've been told that you could help me. I said to him, I'm only a new graduate. I've been told if I see you twice a week for a couple of years, you won't be shuffling like he was. He couldn't raise his arms. He couldn't do this. He couldn't do that. He owned 3,000 acres. He had his own fishing rivers. He had people raising ducks and pheasants and whatnot that he would shoot, and he couldn't do it anymore. And he said to me, when I told him that, he said, I have time and I have money. So I'm going to be here twice a week for 2 years. I thought, oh my God. But in about 18 months, he brought me in 2 pheasant, 2 ducks, 2 snipe, 2 plover that he'd all shot himself. And he came once a month until he died at 99. It was a huge experience, and I thought to myself, how did that happen? So I got into the literature, and I discovered SAID, specific adaptation to an imposed demand. If you have a kinesiology background, you'll understand. You've seen that before. Specific adaptation to imposed demand. So they come into us, and their joints are all locked, and they have what we used to call a subluxation. And we do an adjustment, a manipulation, and we repeat it, and before you know it, the soft tissues around the capsules and the ligaments and tendons, they change their properties. They become elastic again. They allow for movement. The mechanoreceptor message afferentation up to the brain, changes the recruitment order of the muscles, and they start to function again. And it's really, really amazing. I hate to use that word because it's not amazing, it's a scientific fact that when you impose a demand such as weight training and you come to failure, your bicep gets stronger. That's a rule. And when we treat patients that are dysfunctional, we have to continue. But then we have to know when they are dysfunctional and when they're improved from function. And you can't just go by, I feel better, doc. Feel better can happen because of the natural history. You have a cold, it gets better in 7 to 10 days. You take a whole lot of vitamin C, you do all kinds of things, and it takes a week to a week and a half. That's the natural history of getting over a cold. Things do have a natural history. And then there's the placebo effect. Every doctor works the placebo effect. It's not a bad word. Right? Don't be afraid of it. Right? The minute you administer as a doctor, you're going to start getting a placebo effect. Right? That's great. And then there's the therapeusis that you apply. And you should have a good idea of how that's working, SAID, because that's what you're doing. And that'll make you super busy because there's nobody in society doing this. Right? There are physiotherapists doing rehab. There's orthopedics doing what they do. But there's nobody that has the skills of doing manipulation, changing diets, making patients fit, giving them rehab, giving them a sense that they can be well again, hope. When you relieve their pain, you relieve their suffering. They're not the same. The pain is what they're going through. The suffering is that they can't bring food home for their family because they can't work anymore. The suffering is, it's kind of different. And you have to appreciate that and have empathy for not only their pain, but for their suffering. With that, I charge you, I welcome you into the chiropractic profession. It's super, super that you've gone through a really good program. I welcome you.